Hello class, this is Dr. Rogers and I would like to take this opportunity to present your pharmacology review. As you're preparing for your boards, of course you know there's a lot of information that you'll have to review, and pharmacology is one of those areas. Of course, when talking back to students, they're coming back and they're reporting to us that they are having a lot of pharmacology questions on their exam. So we wanted to do a small review for you just to highlight some of the main areas that you may see as it relates to pharmacology. Although we can't cover all of the medications, I do want to take this opportunity to cover some of the major drug classes. It may be a good idea for you to take maybe a drug class a day and just go back over it. There's no way that any of us could remember all of the medications that are out there, all the signs and symptoms. No pharmacist can do that. But we want you to, go over the drug classes, look at some of the similarities between the classes, and hopefully that will assist you in learning your medications and knowing how to apply the information that you know to the patient's situation. And so when we look at strategies for pharmacology questions, of course with any question, and you've learned this throughout the nursing curriculum, to always read questions carefully. Look for the main points, look for keywords within the question, and then you want to identify the subject. When we talk about identifying the subject, we want you to determine if they are asking you about an intended effect, a side effect, or an adverse effect of the medication in question. And so when we talk about the intended effect of medication, well, we're talking about the desired effect or the expected effect, what we expect to happen as a result of the person taking the medication. When we talk about side effects, most medications will have a side effect. Not all side effects are bad. Some side effects are more serious than others. But a side effect is a physiological effect of a medication, but the side effect is unrelated to the intended effect of the medication. And so also with side effects, these effects tend not to be life-threatening. When you talk about maybe some nausea and vomiting, if it's not severe, maybe the person has some GI discomfort, that's a side effect, and those things tend to be non-life-threatening. Now when we talk about an adverse effect is an undesirable effect and can range from being mild to severe. And so when we talk about things like an anaphylactic reaction, that can be a mild to severe reaction. And so with adverse reactions, we do want to report adverse reactions to the physician. And also we want to know if we're looking at a toxic effect of a medication. And so when you're going back and you're reading, you want to go back and look at those medications again that have a narrow therapeutic window. Your medications like digoxin, lithium, dilantin. These are medications that when patients are taking these medications on a routine basis, we have to make sure these patients are being having their labs drawn on a routine basis, because that therapeutic window is so narrow. If they're too low or too high, then definitely if we're too high, then we have some problems with toxicity. And if it's too low, well, then that person is not in therapeutic range. And so if the person is taking dilantin for seizures and the level is too low, well, then they're not going to have that protection to stop possible seizure activity. Also, when you're looking at your questions, you also want to note any strategic or descriptive words. You want to note if it's asking you priority. So we know when we see the word priority, we may have 4 correct options, but which one would we do first? Which is most important? When you see things like least likely, it's least likely. Which thing are we most likely not able to see occur with this patient? Or is it telling you within the question or within the stem that this is a patient that's having some cardiovascular dysfunction? Okay, so we want to look for any descriptive words within the question. And so if we, know that this is a cardiovascular client, well then when we're presented with the medications, this may give us an idea of how to answer the question. Of course, we want to always use the process of elimination. Boards are a little bit different than the exams that we give, of course. Usually with our exams, you can, off the top, narrow 2 of them, eliminate 2 of them. But with the NCLEX, all of them may look correct, but we're hopefully we've prepared you to where you can, eliminate those options that are distractors. And of course, we want you to use your nursing knowledge and the experience that you've gained in the past 2 years of being with us here at Lawson State. So when we talk about the classification system, again, there are numerous drug classes. There's no way that we can go over all the drug classes. I want to go over some of the main drug classes today, but again, while you're preparing for NCLEX and you're doing your questions, you may want to go back to your pharmacology books and take a drug class a day and to just look at some of the similarities with the different drugs and look at some of the more common side effects associated with the drug class. No way to know all of them. No way to know all the side effects. But when you're presented with a question on NCLEX and you don't know, and it's just one that you have not seen before, and I know you've heard this before, try to break the word down. Look at the root of the word. Of course, look at the prefix and look at the suffix. Sometimes just looking at the word, you'll discover clues within the word or the drug name to let you know what this drug class may be. So break the word down, break the drugs down into parts. And then once you do that, once you realize you're dealing with a cardiovascular drug, you want to identify nursing interventions associated with common side effects of that drug. Also, we always want to remember that RNs are responsible for providing education. So any nursing intervention that we provide for our clients should include some type of client education. We want to make sure that our clients know how to correctly administer their medications. We want to make sure that they know the correct dose. We want to make sure that our patients know that they never stop a drug abruptly. Okay? If they're having side effects, if they're having some adverse effects, we want to make sure that they understand they need to call their physician. But we never want the patient to abruptly stop medications. So the first medication that we are going to discuss today, first drug class are ACE inhibitors. And so as you see up here, we have PRIL and parentheses because most of your ACE inhibitors will end in PRIL. ACE stands for angiotensin converting enzyme. And so why do we want to inhibit angiotensin? And so I know everybody remembers that, but we want to stop the conversion of angiotensin 1 to angiotensin 2, which is a vasoconstrictor. What we also have to remember when we're talking about angiotensin is that we have what's called the renin angiotensin aldosterone system. And so once renin is activated, it starts this cascade that activates the angiotensin, the aldosterone. And so what happens then, we already talked about the vasoconstricting effect, but we also have aldosterone being released and ADH. And so if we remember what aldosterone does, aldosterone is a hormone that causes sodium retention and potassium wasting. So that's one mechanism that the person is going to retain water. We have vasoconstriction, the person is going to retain fluid and cause the heart to pump harder. And then we also have antidiuretic hormone, and that's going to cause the person to have further fluid retention, and so it's going to exacerbate hypertension. If the person has heart failure, it's definitely going to exacerbate that heart failure. So this is why we want to inhibit angiotensin. It causes vasoconstriction and excess fluid volume. So I just put down here APRILs. That's a good way to remember angiotensin, is calling them APRILs. So the intended effect, what do we expect to see happen when a person takes an ACE inhibitor? Well, we expect the person to have a lower blood pressure. We expect the person to have improved cardiac output, because now we're improving and increasing vasodilation. So we're opening up those vessels, and by opening up those vessels, we're improving cardiac output, and then we're improving renal flow because we've opened up the vessels, and now we have more blood flow to the kidneys, and so we know that that means that we're going to have increased urine output. So what are our nursing interventions when we have a person that is receiving ACE inhibitors? Well, we know that this is a blood pressure we can use it as a blood pressure medication. We can also use it for CHF, and we have a person that's going to lose fluid. So we know that we've got to monitor this person's blood pressure because they're at risk for hypotensive events. Also, we talked about aldosterone when we had aldosterone being affected with angiotensin. Well, now we don't have the effects of aldosterone, so the person may actually retain potassium. So we have to make sure that we're monitoring our person for elevation in their potassium levels. And we know one of those signs that a person may have elevated potassium, maybe the person, if they're being monitored on telemetry, we may see some elevated T-wave, elevated ST segments. So we want to also make sure that we're monitoring this person's heart rate. Another thing that we want to make sure that we're monitoring, ACE inhibitors, one of the adverse effects is that ACE inhibitors can cause the person to have a lower white blood cell count. So we want to monitor the person for neutropenia, and we know that if it's affecting the white blood cell count, well, then this may be a person that's going to be at risk for infection. So that's one of those things when we're doing labs. We want to make sure that we're looking at the person's white blood cell count. Now, what I put down here, I put down ARBs. ARBs is another drug class that you may see being used with ACE inhibitors. ARBs are your angiotensin receptor blocker medications, and ARBs tend to end in TAN. And so what is the difference between an ACE inhibitor and an ARB? And so what I found in reading is that we have angiotensin receptors all throughout the body. And so while ACE is taking its time to do its job and it's inhibiting the conversion, well, your ARBs are just going to stop the receptors from binding. Okay? And so ARBs and ACE inhibitors can be used together, and when they've been used together, they've been shown to show a decrease in heart enlargement and improve ejection fraction. So ARBs and ACE inhibitors can be used together. A physician may decide to use ARBs. Sometimes ACE inhibitors can cause a patient to have a really bad cough. And so we want to, if the person is having problems with coughing, well, then this may be a patient that would prefer to take an ARB instead of an ACE inhibitor. Okay, so again, nursing interventions, want to make sure that we're monitoring the blood pressure. We want to make sure that we're monitoring the patient's labs, paying attention to potassium, white blood cell count, and we want to make sure that our patients know how to assess their blood pressure. We want to also make sure that they know how to check their pulse. And then if the patient complains of cough, we know that this is common again with ACE inhibitors, and so this is something that the patient could report to us, and ARBs may be an option for this patient. With our antilipemic medication, well, these are our statins, and these are the medications that we commonly use for patients that have high cholesterol. These medications work by lowering the concentration of LDL cholesterol, our low down cholesterol. That's our bad cholesterol. So we want to lower the concentration of the LDLs, and with a patient taking statins, it's going to lower the patient's incidence of, it can lower the patient's incidence of coronary artery disease. We know that we still have patients taking medications and eating whatever they want, and so really you have your diet working against the medication. And so of course when a person is receiving a statin, we still want them to try to we still want to educate them on a low fat diet, a low cholesterol diet when they're taking these medications. Statins are usually tolerated well. So when we look at these medications that have a lot of side effects and adverse effects, well, statins don't have a lot of adverse effects. When you're reading up on statins, the medications that we use, you see them listed here, your Lipitors and Lescals, Provocols. These medications belong to a class called HMG-CoA reductase inhibitors. And so this is what all these medications here, your Lipitor and your Lescal, they're again classified as HMG-CoA reductase inhibitors. And so that's a big word. What is that? And so what this reductase is that we need this in our body. It's required for cholesterol synthesis. So we have to have that reductase for cholesterol to even be made. And so it would make sense that we want to take a HMG-CoA reductase inhibitor because we want to stop the synthesis of cholesterol. The person has too much, so we want to block it. And that's what these type of medications do. If you'll remember, the liver is responsible for producing cholesterol, but it requires HMG-CoA reductase in order to produce cholesterol. And so this is where our statins are going to come in. They're going to come in and they're going to block that activity from occurring in the liver. One of the side effects that we can see with statins, myopathy, is muscle pain, and so it can occur, but it's one of the rare side effects associated with statin usage. This muscle pain can lead to a condition called rhabdomyolysis, and this is when a person has the breakdown of muscle. And so anytime we talk about having a breakdown of muscle, muscle fibers break down into proteins. And so these are large proteins, and if the person has rhabdomyolysis, they're at risk of developing renal failure because the proteins have to be excreted, and so they overwhelm the renal system, and then that overload in the renal system can lead to renal failure. So that makes us know that when we have a person taking statins, we want to make sure that we're monitoring, of course, blood pressure. We also want to monitor urine output. Monitor for any changes in the urine output. The patient may also have to have liver enzymes checked on a regular basis. And the person is going to need to be assessed for excessive elevations in their liver enzymes. Of course, again, we want to monitor the person for complaints of pain, because that complaint of pain, if it's muscle pain, again, we said it could lead to rhabdomyolysis. So we want to make sure that we're monitoring the person for pain, and we're going to monitor urine output. Of course, we can make sure that we're monitoring coagulation, and one of the ways we can do that is the person having elevated bleeding times. We know that the liver is responsible for some of our coagulation factors, so we want to make sure that we're paying attention to that and making sure that we're monitoring the person's liver function test. Benzodiazepines, ending in PAM, usually ending in PAM. Some of the common uses that we see for benzodiazepine use, they help to reduce anxiety. They have a sedative hypnotic effect, not hypnosis like, a magician, but, hypnosis of, the anxiety producing event. Okay. We want to We can also use benzodiazepines as an anticonvulsant. And so the intended effect of benzodiazepine use is that it's going to depress CNS activity, thereby inducing a sedative and hypnotic effect. They can also cause skeletal muscle relaxation, which will be good for the person that has seizures, and then they can also provide anxiety relief. And so here you see some of the more commonly used benzodiazepines, and you've probably seen most of these. You've probably administered most of these medications before in the hospital. Down here I have what if the person has too much Valium or too much Xanax? The medication that we use for an overdose of benzodiazepines is flumazenil or romazicon. That's the medication that's used for overdose. And so when we have a patient that is taking benzodiazepines, we want to make sure that we're monitoring the person's respiratory rate. We want to make sure that when we're taking care of patients that are receiving benzodiazepines, we want to also make sure that we're monitoring the person's level of consciousness. Patients that are having surgical procedures, sometimes benzodiazepines are used as adjuncts with anesthesia. So of course, the person is going to be asleep for a while, but we do want to make sure that we're continuing to monitor the level of consciousness. Patients that have impaired liver function, of course, if they have impaired liver function, these medications can lead to toxicity. We want to always monitor the patient's urine output. We want to make sure that our patients know that when they take these medications with alcohol, that respiratory depression or arrest can occur. Also, these medications have a high affinity for becoming addictive. And so usually when patients are started on benzodiazepines, we want to, start the lowest dosage and frequency that's going to give the person that anxiety relief or produce sedation. So we want to start with the smallest dose possible. With beta blockers are commonly used for hypertension. They can also be used for angina, dysrhythmias, and they can also be used for patients that have glaucoma, open-angle glaucoma. The way that they work is that they block SNS or sympathetic nervous system stimulation, and by doing that, by blocking that stimulation, it causes vasodilation of the blood vessels. It can also affect the heart rate, and then when we block central sympathetic nervous system stimulation, when we talk about the bronchial smooth muscles, beta blockers cause bronchial smooth muscle to contract or vasoconstrict. So blood vessels, beta blockers are going to cause dilation, but with the bronchial smooth muscles, they can cause vasoconstriction. So if you just get to thinking now, we can understand that there's a certain class of people that we, have to use beta blockers with cautiously. Here are your commonly used beta blockers, ending in LOL. And so with our nursing implications here, beta blockers, we said, in the beginning that they're used for hypertension, so we want to monitor the person for hypotension. And since we know that they're going to cause vasoconstriction of the bronchial smooth muscle, well, we got to monitor this person for bronchial constriction. And so we're going to listen to lung sounds to note if we hear any wheezing, okay? Any change in lung sounds. We want to monitor this person for bradycardia. And then we want to monitor the person for signs of heart failure. When we're taking taking care of patients that are receiving beta blockers, we want to educate them on potential drug interactions. Antacids are just one of those medications that need to be taken by themselves. Antacids can decrease the effectiveness of beta blockers, and so what it means is that they're not going to effectively cover or decrease a person's blood pressure if that's why the patient is taking it. when we talk about diuretic use with the beta blocker, diuretics can increase the hypotensive effect, which means that a person taking a diuretic and a beta blocker, it's going to drop the person's blood pressure even more. And a patient that is taking oral hypoglycemic medications and beta blockers, these agents, when they're taken together, they decrease the hypoglycemic effect, which means that the person may have higher blood sugars when they're taking beta blockers and oral hypoglycemic medications. And so these are things that we want to tell our patients. We commonly have patients that are diabetics and hypertensives. And we have patients that routinely take antacids for, a stomach ache. So we want to make sure that they know the possible side effects of taking these medications together. Of course, we want to make sure, again, any of our patients taking hypertensive medications, it's just a good idea for these patients to know how to monitor their blood pressure. Patients that have a history of heart failure, we want to make sure that they know the signs and symptoms that they're having an exacerbation. Is the person heavier? Our heart failure patients, it's a good idea for them to weigh their cells on a daily basis. So are they gaining weight? Are their rings tighter? Are their shoes tighter? We want this person to report any shortness of breath, any increase in the blood pressure. I mentioned earlier that beta blockers can be used for glaucoma, and so what they do for patients that have glaucoma is that they decrease aqueous humor. But we have to know that in addition to a decrease in aqueous humor for the person that has glaucoma, it can also cause the person to have a drop in their blood pressure. So think back when we talked about intended effect and side effect. This person with glaucoma, they're taking beta blockers not specifically because they have a high blood pressure, but they're taking it because it's going to decrease aqueous humor in the orbital area. But one of the side effects, of course, is still that the person can experience hypotensive effects. And so that would be a side effect at that point. With our bronchodilators, they're commonly used for all types of COPD. Asthma, some books will differ in what they classify asthma as, but some books will classify asthma as being a type of COPD or chronic obstructive pulmonary disease. Also chronic bronchitis and emphysema, which are specific types of COPD. And so the intended effect of giving a person a bronchodilator, we expect the person to experience a relaxation of bronchial smooth muscles. We expect those bronchi and bronchioles to dilate, and so therefore the person is going to have impaired airway exchange, improved gas exchange, that exchange of carbon dioxide of oxygen. And so when we talk about the common medications, your aminophylline, theophylline, when we talk about nursing implications, we want to make sure that the person is having levels drawn to make sure that they don't have too much theophylline in their system. We want to make sure that we're monitoring the person's lung sounds, monitoring to see if they're having any increased effort when they breathe, any increase in their shortness of breath. Now, calcium channel blockers tend to end in PINE. Some of the common uses that we see for calcium channel blockers, they're used for dysrhythmias, hypertension, and can also be used for angina. And so why do we want to block calcium? Okay, The reason we want to block calcium is because calcium overstimulates the cardiac muscle and it causes excessive contraction. So that's why we use calcium channel blockers for our patients that have hypertension, because it's going to decrease some of that contraction. And so we can also use it, again, as it says here, for dysrhythmias and angina. And so the intended effect is that the person will have, lower blood pressure. Also, the person can have treatment for tachyarrhythmias. That's a fast arrhythmia. So some of the common medications we use, you see them listed here: your amlodipines or your Norvasc, Cardine, Solar, Procardia. And so we want to make sure when we have patients that are taking, again, any type of cardiac medication, that they know how to assess their blood pressure. We want to make sure that they know how to correctly assess their heart rate. Patients taking amlodipine or Norvasc would not want to take these medications with grapefruit juice, and that is because it's going to increase the amlodipine level or increase the Norvasc level. So not a good idea to take these medications with grapefruit juice. Again, the person will want to, as I said before, monitor the person's blood pressure. Want to, again, monitor this person for any weight gain, any new edema. The person may have postural hypotension. So again, we want to tell the person to change position slowly, dangle the feet before rising to stand, monitor the heart rate. Again, always make sure they're reporting any new edema, any facial edema, swelling in the extremities. These could be signs of heart failure. So we want the patient to report those things, report any new shortness of breath or palpitations to the physician. Glucocorticoids, these medications, they have numerous uses, and I've just listed some of them up here for you. Adrenocortical insufficiency, cerebral edema, COPD exacerbation, dermatological diseases, patients that are having organ transplantation, we can use glucocorticoids to decrease the immune response. And we want to decrease the immune response because we want to stop the immune system from attacking the new organ, because the body may see it as being foreign. The intended effect of glucocorticoids, well, they may have anti-inflammatory actions. They're used for fat metabolism. They're needed for maintenance of normal blood pressure, and they also have stress effects. And so you see down here some of the more commonly used glucocorticoids. Most of us have seen prednisone before. We've given it, we've probably used it, or we've had children to use it. So these are some commonly used medications. And so when we're talking about patient education, we want to make sure that our patients know not to abruptly stop these medications, because it can precipitate a crisis. And so they should not abruptly stop these medications. Patients that are taking corticosteroids on a long-term basis may develop what's known as Cushing syndrome, and that's when the patient develops a puffy appearance. So we want to make sure that the person knows about the possible body image changes. We want to monitor the person's glucose, because when a person is taking glucocorticoids, it can cause an increase in glucose levels. And so typically when we have patients that are receiving steroids in the hospital, they'll say, well, I'm not diabetic. Well, we know that when they're taking the glucocorticoids, it can cause a release of insulin and cause the glucose levels to be elevated. So we want to make sure that they know that we're not saying that you're diabetic. The steroids cause a release of glucose, and so we may have a person that is going to have insulin coverage while they're receiving steroid therapy. Also, we need to remember that steroids can also cause potassium depletion. So we want to monitor our patients for signs of hypokalemia. The person may have decreased healing when they're taking corticosteroids, and we know that the person is at increased risk of infection because we have corticosteroids decreasing the immune response within the body. It's decreasing inflammation, but it's doing that while it's decreasing the immune response. So we want to monitor the person for signs of infection. Patients, again, taking steroids on a long-term basis should know that they need to avoid crowds when they're on steroid therapy. With H2 antagonists, these are medications that we commonly use for GERD, or gastroesophageal reflux disease, or PUD, which is peptic ulcer disease. These medications can also be used for erosive esophagitis, and they can be used to control upper GI bleeding. And the intended effect of these medications is that they're going to reduce acid secretion. With H2 antagonists, the drug effects of H2 antagonists are decreased hydrogen ion production from the parietal cells, which results in an increase in the pH of the stomach and relief of many of the symptoms associated with hyperacidic secreting conditions. And so again, when we give these medications, they're going to increase the pH of the stomach. And H2 antagonists are normally not administered with other medications because they affect absorption. So when we look at some of the side effects, you see here cimetidine, and cimetidine is the medication that tends to have more side effects than the other medications. And so when we look at the side effects, some of the side effects we see impotence, gynecomastia. We typically see that with cimetidine, and they can also cause a person to have increased prolactin secretion. Also, what we have to know about cimetidine use is that it may raise blood concentration of medications such as theophylline. It can also raise blood concentrations of warfarin, lidocaine, and also phenytoin or dilantin. So what we see here is that the person may have to have these levels assessed for possible toxicity when they're taking cimetidine, in addition to, again, your warfarin, lidocaine, phenytoin, and theophylline. The person is at risk for toxicity when they're taking cimetidine. So with our nitrates, we commonly use these medications. As it says here, they can be used prophylactically when a person is having chest pain, and they can also be used for treatment of angina. And so what do we expect these medications to do? Well, we expect vasodilation. We expect the person to have relaxation of smooth muscle cells, particularly dilating the coronary arteries. And so our nursing implications here, one of the more common side effects of a person using nitro is headache. That's the most common side effect because we're vasodilating all the vessels, and so we're also vasodilating the cerebral vessels, and so we're increasing blood flow to that area. And so headache is one of the common side effects. The person may have tachycardia and some postural hypotension. We also need to educate our patients, some of our older patients, that you can't take nitroglycerin with Viagra. Both are vasodilating drugs, and so they can cause the person to have a dangerous drop in their blood pressure. So again, make sure that they don't take these medications together. Also, a person that's taking nitro, they need to know that if they're taking this medication in addition to beta blockers or calcium channel blockers, that they're going to have an additive hypotensive effect, meaning that the blood pressure is going to decrease more. So we want to make sure we're monitoring our patient's blood pressure when they're on nitrates and other cardiovascular meds, and the person may need IV fluids to help increase their fluid volume. Okay, proton pump inhibitors ending in ZOLE. We commonly use these medications for GERD maintenance. They can also be used for the treatment of duodenal ulcers, H. pylori infections. The intended effect of proton pump inhibitors is that they block all acid secretions. And so you see here some of the common medications listed, some of the common medications used. And so when we have patients that are using proton pump inhibitors, these patients may be at increased risk for GI infections because we're blocking all the acid. And so acid has a protective effect in that it blocks some antimicrobials. And so when we block all the acid, well, then we're blocking that antimicrobial protection. And so the patient is at risk for GI infections. Patients that are taking proton pump inhibitors, these medications may increase serum levels of diazepine and dilantin. So again, all of these different GI medications, antacids, H2 antagonists, proton pump inhibitors, is just a good idea maybe to take these medications an hour before or after greater of taking our other medications. With our sulfonamides are a group of medications. They're a type of antibiotic, and so we commonly use sulfonamides for bacteria infections, and they have been shown to be particularly useful in treating urinary tract infections. Sulfonamides, with the intended effect, is we expect the inhibition of the growth of the enzyme that is essential for the growth of certain bacteria. So sulfonamides are going to block that bad bacteria. They're going to block it. So sulfonamides don't destroy bacteria, remember that, but they inhibit their growth. So sulfonamides are going to be contraindicated for patients that have a sulfur allergy, of course. And other medications that are chemically similar to sulfonamides are contraindicated. Some patients, your diabetic patients, if they have a sulfur allergy, they can't take sulfonylureas, which are a group of oral antidiabetic medication. So we want to always assess for allergies, and then again we want to make sure that we're assessing or determining what the person's current medication regimen is. With thiazide diuretics, they end in ZIDE, commonly used to treat edema of various origins. We may see it being used for the treatment of hypertension, heart failure, cirrhosis. The intended effect is that they're going to promote the loss of excess fluid volume. Hydrochlorothiazide is the most commonly used thiazide diuretic, and so what we have to remember about this thiazide diuretic is that it is a potassium sparing diuretic, and so we can't use this medication with patients that have renal failure. They're typically not used in pregnant patients, and our patients that are dehydrated, we wouldn't use a diuretic because we're going to further, cause them to lose more fluid volume. Patients that have hyperkalemia, this would not be the patient that could use a thiazide diuretic. I want to do a little segue at this point. we're talking about thiazide diuretics, but we also know that we have loop diuretics. Furosemide, Lasix is one of the diuretics that we've learned about from semester to semester. And we know that these medications are potassium wasters. And so one of the things that I want you to remember is that some patients may take digoxin, which is a cardiac glycoside. And so what we have to remember when we have patients that are taking diuretics and digoxin is that digoxin has a very narrow therapeutic window. The therapeutic window for digoxin is 0.5 to 2 nanograms per milliliter. When a patient has low potassium levels, it can cause the digoxin levels to increase. And so with that, the person, once they have a low potassium, they can become what we call dig toxic. And so we want to make sure that we're monitoring our patients that are receiving digoxin. We want to monitor their dig levels, and we also want to make sure that we're routinely checking the person's potassium levels, because again, a drop can cause the person to become dig toxic. Now, there is a medication, an antidote for dig toxicity, and it's called Digibind. And so we're binding that excess dig, right? The signs that a person may be dig toxic, the person may complain of dysrhythmias, palpitations, colored vision. They may say that they see yellow halos around lights. They may complain of flickering lights are flickering. And so these are signs of dig toxicity. And so you want to make sure that you remember that a low potassium can cause a person to have dig toxicity. Again, we have a person that is losing fluid volume, so we know that there's a risk for hypotension. The person may lose sodium, may lose chloride, all those other electrolytes that we talked about. You know, when a person is receiving diuretics, they're at risk for an electrolyte imbalance. So make sure you go back over your fluid and electrolytes and what we look for when a person has low levels of different electrolytes. With our thyroid hormones are commonly used to replace hormones that the thyroid can't produce. So we typically see thyroid hormones being used for the treatment of hypothyroidism. The intended effect is that the person is in a state of euthyroid, which means that they have normal thyroid levels. We want to make sure that we're, when we have a person and we're replacing thyroid, that the person's thyroid levels are not too high. If they're too high, then we see those signs of hyperthyroidism. The person may start to lose weight. We remember the bulging eyes that we see with hyperthyroidism, increase in metabolism, the person eating eating excessively and losing weight. So make sure you go back over the signs and symptoms of hyperthyroidism as well as hypothyroidism. And so thrombolytics, the next class, typically in an ACE, or ASE, they're commonly used to dissolve clots. So clots that form arterial thrombosis, DVTs, occlusion of shunts or catheters. So again, thrombolytics are going to lyse clots. And so we intend to see the restoration of blood flow to a formerly impeded area. You see here the commonly used thrombolytics. What we have to remember about thrombolytics is that they are not clot specific. So in addition to lysing a clot, they can also cause the person to be at increased risk of bleeding. So when we have patients that are receiving thrombolytic therapy, they are at risk for internal bleeding, intracranial bleeding, and also superficial bleeding. So we have a person receiving thrombolytics. We're going to monitor them for increased risk of bleeding. What we have to remember, another little segue, we have anticoagulants and thrombolytics. So what determines the use of either one? When we give a person anticoagulants are prophylactic medications. We give these medications to make sure that a person does not develop a clot. If a person already has a clot, anticoagulants are going to help that person to not develop further clots. But anticoagulants do nothing for existing clots. If the person has an existing clot, that's where we use thrombolytics to come in and to dissolve a clot. But anticoagulants do not dissolve existing clots. And I put this slide here because I want you to go back and review your different anti-diabetic medications. We know that oral hypoglycemic medications can only be used for our type 2 diabetics because oral hypoglycemic medications are going to stimulate insulin in the body. Well, we know that our type 1 diabetics don't have that pancreatic release of insulin, so we can't use oral hypoglycemic medications with type 1 diabetics because the pancreas does not function properly for them. Well, our type 2 diabetics, we know that the pancreas may still have some function, and so the oral hypoglycemic medications are going to play on that function that the pancreas still has for the type 2 diabetics. So make sure you go back and read over the different types of oral hypoglycemic medications. What I want you to remember is that patients that have to have different type of procedures that require contrast media, these patients have to stop their oral hypoglycemic medications for 48 hours within having that contrast medium. So make sure you remember that. Also make sure that you go back over the different type of insulins, your regulars, your NPH, your Lantus, how they act when they peak, so that we know how to treat our patients. We know our intermediate medications, they're going to act throughout the day. Your Lantus is going to act throughout the day. We give that because it acts as a basal insulin to cover the person throughout the day. But we also know that patients may still have spikes in their blood sugars even when they're receiving Lantus, and so these patients may receive your short-acting insulins like your regular or like your Actos, which is a rapid-acting insulin. Okay, so make sure you go back over your medications, your anti-diabetic medications. Again, go back to your pharmacology book, take a drug class a day, look for some of those common signs and symptoms that you're going to see associated with your different drug classes. We expect great things from you. We expect to hear your good news, and if you need anything from us, please don't hesitate to call. Thank you.